Okay, so for today, we'll discuss carbohydrates and um, the different types of diabetes, and we'll also discuss GSDs or inborn errors of carbohydrate metabolism. Example, you have your GSD or glycogen storage disease. And also, we'll discuss the different methods to measure glucose level. Okay, so before we'll proceed to our discussion regarding the different types of diabetes, we'll talk about first what is osmolality and what are the main contributors um, of osmolality. Okay, so when you say osmolality, it's the ratio between solute and your solvent. And the solvent, okay, for our osmolality, it's our plasma. Okay, and solute, you have the substances present in your or present in our blood. Okay, so that's solute over solvent. Okay, now what are the main contributors of osmolality? So first you have sodium, glucose, and blood urea nitrogen, or BUN, or urea. Okay, so these are the three main contributors of osmolality. Okay, three main. Okay, now let's say uh, the normal osmolality. Okay, so for example, you have 10 substances divided by 1 liter of uh, solvent. So 10 divided by 1, that is 10. So the osmolality is 10. Okay. Now, for example, if the patient has diabetes, okay, so we'll expect that there is increase in glucose concentration. So we'll add another 10. Okay. So 10 plus 10 divided by 1, that is 20. So there is an increase in osmolality due to the increase in glucose concentration. Okay. Now, for a body um, to return to its normal osmolality, uh, the body needs to increase, okay, the level of or the volume of plasma. So we're going to add 1 liter, okay, so that it will return to 10. So 10 plus 10, that's 20, divided by 1 plus 1, that's 2. So 10 divided by 2, no, 20 divided by 2, that is 10. So uh, that's how our body returns to it, or how our body returns to its normal osmolality. Okay, by altering the level of solvent if the problem is in the concentration of solute. Okay. So next is the response of our body to increase in osmolality. So this is the normal, okay, normal responses of our body to increase in osmolality. So first is the activation of the thirst mechanism. And we say thirst mechanism, it is controlled by our hypothalamus or by the hypothalamus. Okay, so if you have damaged hypothalamus, there's a possibility that you'll have altered thirst mechanism. Okay, and that's the main cause of uh, hypernatremia. Okay, or increased sodium concentration. Okay, now regarding this one, the purpose of the activation of thirst mechanism is to stimulate, okay, or not just stimulate, no, but the effect of the activation of thirst mechanism, the person tend to drink, uh, or the effect is the person will drink water, okay. So the purpose of that drinking of water is to increase the plasma volume. Okay, so that the osmolality will return to its normal level. Okay. Next is secretion of ADH. So ADH is antidiuretic hormone. It is produced by the hypothalamus and stored and released in the posterior pituitary gland. Okay. So the purpose of ADH is to reabsorb or to retain water, okay? So that the solvent, the volume of solvent will increase, okay? Next is the transfer of fluid from intracellular to extracellular, so meaning the fluid inside the cell will transfer to the extra or will mix with the extracellular fluid, okay, to increase the volume of solvent, okay. Next, you have signs and symptoms of diabetes mellitus. Okay, so first is polyuria. So for polyuria, you have increased urine volume. Okay, uh, um, so the reason for this one is first, it's the renal threshold for glucose. The renal threshold for glucose, it's from 160 to 180 mg per dl. So once the glucose concentration reach 160 to 180, the body will try to eliminate the excess glucose via urination. Okay, so that's why there is polyuria. Okay, the body is trying to eliminate the excess glucose via urination. So that's the reason why there's polyuria in diabetes mellitus. Okay, next is polydipsia. So for polydipsia, you have increased sensation of thirst. Okay, so for polydipsia, uh, frequent ka thirsty ang person. Okay, or an individual. It's because reason for this one is to compensate. Okay, the effect or to solve the or to eliminate the effect of polyuria. Okay, kaya diba, for in polyuria, you have increased urine formation. So to balance, okay, the fluid loss or to eliminate the effect of fluid loss, that's why the person uh, or the individual will drink more water. Okay. Another is to maintain osmolality. Okay. So for example, if there's an increase in solute, increase in glucose concentration, your body will try to stimulate the thirst mechanism to drink more water in order to increase the plasma volume. Okay. Next is polyphagia. So for polyphagia, there's increase in hunger. Okay. So you tend to eat more. Okay. So that's for polyphagia. So for polyphagia or excessive eating, uh, there's polyphagia because the individual with diabetes has problems, okay, with either insulin resistance or insulin deficiency. So meaning the glucose molecule present in blood cannot enter the cell or cannot be used as source of energy. So that's a stimulus, okay, for your body to eat more. Okay? Because na-sense sa body nga uh, you have problems with the levels of glucose because your cells cannot utilize glucose due to the absence of insulin or insulin resistance. Okay, so that is for polyphagia. Next is rapid weight loss. So for the reason for this rapid weight loss is due to the inability of your body to utilize glucose. Now, if your body cannot utilize glucose or there's a depletion in glucose, the next source of energy will be fat. Okay, and the effect, you have weight loss because you're utilizing fat as source of energy. Okay. The next is hyperventilation. So this one is a compensation to metabolic acidosis. Okay, so let's go back to the formula. pH is equal to bicarbonate over CO2. Okay, now in diabetes, particularly in type 1 DM, you have excessive fat metabolism because of the due to the absence of insulin. So you'll use fat uh, f- as source of energy. And when you metabolize fat, or if there's excessive metabolism of fat, you'll have, or the patient will experience ketoacidosis. Okay? Now, in ketoacidosis, the bicarbonate level is decreased. And why there is ketoacidosis is due to the increase in ketone production because ketones are acidic. Okay? So, decreased bicarbonate. So, the effect, you have decrease in pH. So, the individual with diabetes will experience metabolic acidosis. Okay? And that is example of metabolic acidosis is diabetic ketoacidosis. Okay. Now to increase or to return to its normal blood pH, the body has compensatory mechanism. And to compensate that one, we need to alter the CO2 level via lowering, okay, lowering the CO2 or to lower the CO2 level in your body. Okay, and how to lower CO2 level in your body? It's via hyperventilation. Okay, so decrease CO2, we have increase in pH. So you'll have normal blood pH. So that's the explanation of hyperventilation in diabetes mellitus or Kussmaul-Kin respiration. Okay. Another, you have mental confusion and possible loss of consciousness. Okay. And gastroparesis. Okay. So gastroparesis, there is vague abdominal pain. Okay. So the reason why there's gastroparesis is because the vagus nerve is affected. Okay. By diabetes due to there is neuropathy. Okay. Or nerve damage. So the vagus nerve is also affected. Okay. Next is you have laboratory findings in hyperglycemia. So what are the expected laboratory results in patients with hyperglycemia or patients with diabetes mellitus? So first is increased glucose in urine and in plasma. So first is there's increase in glucose plasma concentration because of the inability of the body to use glucose as source of energy due to deficiency in insulin or resistance to insulin. The glucose cannot enter the cell. So there's accumulation of glucose in our plasma. The next is if the glucose concentration reach the renal threshold, which is 160 to 180, then the next thing that will happen is um, the body will try to eliminate the excess glucose via urination. And that's why there's increase in glucose concentration in urine. Okay, so that's the first two laboratory findings. You have increased glucose in urine or increased urine glucose and increased plasma glucose level. Okay. Next is increased urine specific gravity. And the reason why there's increase in specific gravity sa urine, it's because of the increase in glucose in urine. More substances, the heavier the uh, specimen. So it will have increased specific gravity. Okay. Then next is increased ketones in serum and urine. It's due to increased fat metabolism. Okay, because the body is not efficient in breaking down glucose as source of energy. So the next source of energy will be fat. And if there's fat metabolism, the product of fat metabolism, you have ketones. Okay. The next is decreased blood and urine pH. It's due to ketones, the presence of ketones. Ketones are acidic. Okay. The next is electrolyte imbalance, low sodium and high potassium. Okay. So for this one, for high potassium level in serum or plasma, it's because of the transfer of potassium from intracellular to extra in exchange for the excess H plus. So H plus, you have transfer of H plus from extra to intra. Okay, so there is an exchange of potassium and hydrogen. Because in diabetes, in diabetic ketoacidosis, diba, you have increased H plus because it's acidosis, you have increased H plus concentration. And one way for body to um, neutralize or to return to its normal pH level is by exchanging H plus with K plus. Okay, so you have the transfer of K plus from intra to extra and transfer of H plus from extra to intra to maintain electroneutrality. Okay, then the low sodium level is due to the transfer of fluid from intra to extra. So there's dilutional effect. Okay, transfer of fluid from intra to extra. So the effect you have increase in plasma volume. Okay, so there is dilution of sodium. Okay. Okay, so next is the different types of diabetes. So first is you have type 1 diabetes mellitus, formerly known as insulin-dependent diabetes mellitus. So type 1 diabetes mellitus patients are highly dependent on insulin administration. Okay, so that is why it's formerly known as insulin-dependent diabetes mellitus. But there are cases of type 2 DM that needs insulin administration. Okay, so insulin-dependent diabetes mellitus, that term is not appropriate for type 1. That's why we use type 1 diabetes mellitus nowadays. Next is juvenile onset diabetes mellitus because type 1 is common in children. But nowadays, you have increased number of cases of type 2 in children, and it's due to lifestyle. Okay, it's because of fast food, the um, processed food that children consume. Okay, next is brittle diabetes mellitus because usually individuals with diabetes mellitus type 1 are skinny. Okay, then ketosis-prone diabetes mellitus. But type 2, there are cases of type 2 that will also develop ketosis, okay, or ketoacidosis. Okay, so the appropriate term, it's type 1 diabetes mellitus. Okay. Next, cellular-mediated autoimmune destruction of beta cells. That is the cause of type 1 diabetes mellitus because type 1 diabetes mellitus, it's an autoimmune disease. So your body is producing autoantibodies that destroy the beta cells. Okay? And since there's a destruction in beta cells, you have decreased production of insulin. Okay? So, and if there's low level of insulin, um, the effect, you have increased glucose concentration in your blood because the glucose molecule cannot enter the cell, okay, or cannot be utilized by the cell as a source of energy. The next, in type 1 diabetes mellitus, there is insulinopenia or absolute insulin deficiency because of beta cell destruction. Okay. Next, 80 to 90% destruction of the beta cells. Um, there's a presence of symptoms now of type 1 DM. Okay, if 80 to 90% of beta cells are being destroyed now or are destroyed now, then the patient will develop the symptoms, the typical symptoms of type 1 DM. Next, genetic association. So for uh, type 1 diabetes mellitus, it's coded or present in HLA-DR3 and DR4. And HLA-DR3 and DR4 are present in chromosome number 6. Okay. Now, what are the typical autoantibodies that are present in type 1 diabetes mellitus? Because it's an autoimmune disease, diba? So, autoantibodies, you have glutamic acid decarboxylase and insulin autoantibodies. So, this one is common in adults, glutamic acid decarboxylase. And for children, you have insulin autoantibodies. Now, for the complications, usually the complications of type 1 DM, more of microvascular complications. So small blood vessels. So example, you have nephropathy. So for nephropathy, that is kidney damage. So type 1 DM patients are prone to nephropathy or kidney damage. The next is retinopathy. For retinopathy, that is um, eye damage or blindness. Okay, so the excess glucose can cause problems to the blood vessels surrounding that area, and that can cause blindness. Okay. The next is neuropathy. Okay, neuropathy or nerve damage. So that's why individuals with diabetes mellitus will experience numbness. Okay, it's because of neuropathy. Okay, so that is um, for type 1 diabetes mellitus. Okay, so regarding nephropathy, okay, or kidney damage, um, usually if the patient has kidney damage, the expected or if the kidney damage of the person started na, or the individual, the kidney disease of the individual has started, usually the result of his chemical urinalysis will have a trace, okay, trace result, okay, of proteins. Okay. Now, regarding trace result of proteins, if you exercise within 24 hours, within 24-hour period uh, before the collection of the urine specimen, usually you'll have trace result. Another cause of trace result of protein in your chemical urinalysis, it's fever or infection. Okay, so you'll have your trace result. But if you did not exercise and don't have fever or disease, then the possible cause of trace result in your chemical urinalysis is early um, glomerular dysfunction. Okay, so if you have two results that are two trace results, okay, of proteins in your urine, usually the next test to perform is to check for microalbuminuria. And for microalbuminuria, it's an early indicator of glomerular dysfunction and it precedes nephropathy associated with type 1 DM. Okay, so the usual result, or no, for microalbuminuria, the result is greater than, okay, 30 microgram per milligram creatinine. So meaning it's the ratio between albumin and creatinine. So if the result or uh, the ratio between albumin and creatinine is greater than 30, then that is an indication of, or that is an indication of microalbuminuria. Then the person has microalbuminuria is if the or an individual is said to have microalbuminuria if 2 out of 3 specimens submitted for testing within 3 to 6 months period are with abnormal results, or meaning greater than 30 microgram per milligram creatinine. So that's for microalbuminuria. And remember, microalbuminuria, it's an early indicator of glomerular dysfunction. Next, you have the samples for glucose measurement. So first you have RBS. And for RBS, it's not that reliable in diagnosing type 2, type 1 DM. But you can use this one during emergency cases. It's usually requested during insulin shock and hyperglycemic ketotic coma or to diagnose hypoglycemia. Okay, you can use RBS. So for RBS, the normal concentration is less than 200. Okay, less than 200 mg per dl. Okay. For FBS, it is a measure of overall glucose homeostasis, and the patient should fast for at least 8 hours. That's for FBS. And non-diabetic, it's less than 100. Pre-diabetic, it's 100 to 125. And diabetic is greater than or equal to 126 mg per dl. So that is for FBS. Okay. And to diagnose diabetes, you need at least two FBS results of greater than or equal to 126 mg per dl. Okay. Next is your 2-hour postprandial blood sugar. So it measures how well the body metabolizes glucose. And the meaning of postprandial is after eating. Okay, 2 hours after eating. So the normal 2-hour ppbs level, it's 90 to 130 mg per dl. Okay. Then next, you have your glucose tolerance test. So it's a multiple blood sugar test. It's a multiple blood sugar test because you need to collect 3 samples. So, for example, for OGTT, the patient should fast for at least 8 hours. And after 8 hours of fasting, the next step is to collect the first blood specimen. And that first blood specimen is for your FBS or fasting specimen. Then after the first blood collection, next is the administration of glucose load. So the standard glucose load for OGTT is 75 grams. And after glucose administration, next is to collect the second specimen 1 hour after glucose administration. Okay, so that's your second specimen. Then after that, you need to collect the third specimen. So when to collect the third specimen? 2 hours after glucose load. Okay, so we have 3 specimen to be collected for OGTT. Okay, so it is used to determine how well the body metabolizes glucose, and it's usually performed to diagnose GDM, okay, or gestational diabetes mellitus. It's not generally recommended for routine test, okay, not generally recommended for routine test or for diagnosis of type 1 and type 2, but you can still use it. Okay, if you're going to use OGTT to diagnose diabetes mellitus, the significant specimen is the third specimen, the specimen collected 2 hours after glucose load. And the parameters for that one, for this specimen, the third specimen, it's non-diabetic if the result is less than 140 for the third specimen. It's pre-diabetic if the result is from 140 to 199, and it's diabetic if the result is greater than or equal to 200 mg per dl on at least 2 occasions. Okay, so that is for OGTT. Okay, for GDM, it has different criteria. Okay, for GDM. Okay. Okay, so next, what are the requirements for OGTT? So first is the patient should be ambulatory. So you cannot perform OGTT on a bedridden patient. Okay, it's because bedridden patients has bedridden patients have altered glucose metabolism. Okay. Next, unrestricted diet. Okay, unrestricted diet of 150 grams carbohydrate per day, 3 days prior to testing. Okay. The patient should not smoke or drink alcohol prior to testing because smoking increases glucose concentration and alcohol decreases glucose concentration. And the patient should fast for at least 8 hours. Then the glucose load is 75 grams. Okay, 75 grams. And the standard glucose load, it's 1.75 grams per kilogram body weight. Okay. So, I know 75 grams, this is for adults, but for pedia patients, you have 1.75 grams per kilogram body weight. Okay. But you should not exceed the 75 grams glucose load. So, for example, if the weight of the patient is 100 kilos times 1.75, the result of that is uh, 175 grams. Okay, you should not exceed the standard glucose load, which is 75 grams. Okay, so the maximum it's 75 grams. But for pedia patients that cannot reach this, for example, no, let's try. So, for example, if the weight of the pedia patient is uh, 40 kilos. So 40 times 1.75, that is 70. So 70 is the glucose load. Okay, if 40 kilos, for example, 50 kilos times 1.75, the result is 87.5. So if the weight of the patient is 50 kilos, then you should use the standard glucose load, which is 75 grams. Should not follow the computation 1.75 times the body weight in kilos or kilograms. Okay, so maximum is 75 grams. And it's not suitable for patients with gastrointestinal disorder, because patients with gastrointestinal disorder, they tend to their gastrointestinal tract cannot absorb the glucose being administered. Okay, so for patients with gastrointestinal disorder, the appropriate test is IV-GTT, not OGTT. Okay, because for oral glucose tolerance test, the patient uh, is required to drink. Okay, or the administration of glucose is via oral administration. So we'll have a problem na sa pag-absorb sa glucose. So to avoid that problem, that's why the preferred method of glucose tolerance test in patients with gastrointestinal disorder, it is IV-GTT. Okay, so for IV-GTT, um, this is preferred for patients with gastrointestinal disorder, and the glucose rule is zero point zero 0.5 gram glucose per kilogram body weight given within 3 minutes. And fasting is also required to get the fasting specimen. So zero point 0.5 administered within 3 minutes. For oral glucose tolerance, you have 75 grams glucose administered within 5 minutes. Okay? So for IV-GTT, given within 3 minutes. Okay, so another test that you can use to diagnose diabetes or to monitor glucose concentration, it's glycosylated hemoglobin or glycated hemoglobin. So what is the diagnostic significance of glycosylated hemoglobin? Before we'll talk about the diagnostic significance, what is glycosylated hemoglobin? It is the hemoglobin with an irreversibly attached glucose molecule. That is your glycated hemoglobin. And irreversibly attached siya. So what are the diagnostic significance of glycosylated hemoglobin? You can use this one to monitor. It's for monitoring of long-term glucose control. Uh, so it reflects the glucose concentration for the past 2 to 4 months. Because the RBC lifespan, the average RBC lifespan is 120 days or 4 months, di ba? And your RBC contains hemoglobin. Hemoglobin with an attached glucose molecule. Okay, irreversibly attached glucose molecule. And for glycosylated hemoglobin, it's usually performed every 3 to 6 months in individuals with diabetes to monitor glycemic control. So usually, glycated hemoglobin, it's usually used to monitor, but you can also use this one to diagnose diabetes. So to diagnose diabetes, you have three tests: FBS, Type 1 and Type 2, diagnosis of Type 1 and Type 2. FBS, OGTT, the 2R OGTT, the third specimen, and your HbA1c or A1c, or your glycosylated hemoglobin. Okay? Now, for glycosylated hemoglobin, dietary status has no effect, meaning fasting is not required in the measurement of glycated hemoglobin. Okay? Fasting is not required in the measurement of glycated hemoglobin because wala yung effect imong fasting because it's for long-term monitoring man. And the specimen for glycosylated hemoglobin is EDTA whole blood because we need that RBC that contains your hemoglobin. So normal, it's less than 5.7%. Pre-diabetic, it's 5.7 to 6.4. Diabetic is greater than or equal to 6.5%. Okay? Now, the disadvantage of glycosylated hemoglobin, it's not suitable for patients with shortened RBC lifespan. So, for example, people or individuals with hemolytic anemia, they tend to have shorter RBC lifespan. Okay? So, If there is short RBC lifespan, the effect, you have decreased glycosylated hemoglobin concentration. Okay, so glycated hemoglobin is not suitable for patients with with shortened RBC lifespan. So the alternative is to perform fructosamine instead of glycated hemoglobin. Okay, so if there's an increase, 1% increase in glycosylated hemoglobin, it's equivalent to 35 mg per dl plasma glucose na increase, or increase of 35 mg per dl of plasma glucose. Okay, so that's for glycosylated hemoglobin. Next, you have fructosamine. So this is the alternative. If the patient has hemolytic anemia, then the appropriate test is fructosamine or your glycated albumin. But it is used in monitoring short-term glucose control. So it reflects the glucose concentration for the past 3 to 6 weeks. Okay? So it's for monitoring diabetic individuals with chronic hemolytic anemia. Okay, because in chronic hemolytic anemia, there is decrease in RBC lifespan. Decreased RBC lifespan, you have decreased glycated hemoglobin. So to avoid false decrease, that's why you're going to use fructosamine. Okay, and regarding fructosamine, it should not be correction should not be measured in cases of low plasma albumin. So instances or diseases with low plasma albumin first, if there is liver failure, okay, and kidney failure. So for liver failure, you have decreased albumin due to decreased production. Okay, decreased production because liver is responsible for the synthesis of substances like albumin. Okay, then kidney failure have increased excretion of proteins. Okay, increased excretion. The kidney cannot filter properly. Okay, the proteins. Okay, so you have increased excretion of proteins. So the effect, you have low albumin. And if the patient has low albumin, the fructosamine level will also be affected. It's also decreased. Okay. Fasting is also not required, and not a requirement for fructosamine because the recent meal has no effect to fructosamine level. Reference range is 205 to 285 micromole per liter, and specimen for fructosamine, it is serum. Remember, it's serum for fructosamine at the whole blood for glycosylated hemoglobin. Okay, so that is for um, uh, fructosamine. Okay, next is type 2 diabetes mellitus. So formerly known as non-insulin dependent diabetes mellitus, but for type 2 DM, this one is not applicable na because there are cases of type 2 DM that requires insulin administration. Okay. The next is adult type diabetes mellitus. Adult type because it's common in adults. But nowadays, there are children with type 2 DM because of lifestyle. Next, stable diabetes mellitus. Ketosis resistant, but there are cases of type 2 DM that will develop ketosis or ketoacidosis, and receptor deficient diabetes mellitus. Now, in type 2 DM, the receptor, we have there's no deficiency in receptor or insulin receptor. The problem is the receptor is resistant to insulin. Okay, so for type 2 diabetes mellitus, the cause is insulin resistance. Okay, that's for type 2 DM. So regarding medications, no, for type 1, uh, yeah, it's dependent on insulin. Okay, so the primary medication for type 1, it's insulin administration. For type 2, it's oral agent like metformin. But if the patient cannot change his or her lifestyle, that's the time the doctor will prescribe insulin injection for type 2 DM. Okay, so the primary medication, you have oral agents like metformin. Okay, but if the patient cannot change his or her lifestyle, then there's a tendency that the doctor will prescribe insulin administration for type 2 DM patients. Okay. So what are the risk factors for type 2 DM? So first is obesity. So if you're obese, you tend to develop insulin resistance. Okay. Next is family history, advanced age or old age, lack of exercise. Okay. Because exercise increases insulin sensitivity. Okay. So lack of exercise, the effect you have insulin resistance. Next, GDM. Okay. Gestational diabetes mellitus. So 30 to 40% of cases of GDM tend to convert to uh, DM or type 2 DM 10 years after pregnancy. Okay. Impaired glucose metabolism or pre-diabetic state. Okay, that's another risk factor of diabetes. So for type 2, it has milder symptoms compared to type 1. So for example, with the weight loss, for type 1, it's usually rapid weight loss, but for type 2, it's usually gradual weight loss. Okay, so 45 years old and older should be screened for diabetes every 3 years, and this is for those who does not have hello family history of diabetes. But for patients with family history of diabetes, so you should screen for diabetes uh, much earlier. So, for example, 30 years old or before 45. Okay. So, for patients with history of DM. Then next, you have methods of glucose determination. So, I think it's already discussed in your laboratory class. So, for methods, you have chemical and enzymatic. Okay. So, for chemical example, you have your alkaline copper reduction method. Okay. So you have the reduction of cupric to cuprous ions because glucose is a reducing sugar. Same with ferric to ferrous because glucose is a reducing sugar. Now, the problem with the chemical method, it's not that specific. Okay. Why? Because there are other reducing substances, and those reducing substances can also reduce cupric to cuprous and ferric to ferrous. Okay, so chemical is not that specific. That's why the routine method, it's an enzymatic method, which is your glucose oxidase method. And for the reference method, you have your hexokinase method. So these are the two enzymatic methods for glucose measurement. For chemical, you have copper reduction and ferric reduction method. Okay. Then next, other specific types of DM. So first is pancreatectomy. So for pancreatectomy, you have the removal of a portion of the pancreas or the whole pancreas. So the effect, you have decrease in beta cells. Decreased beta cells, you have decreased insulin production. Okay? So the diabetes is secondary to the removal of the pancreas or part of the pancreas. Okay? Next, endocrine disorder. So example, you have Cushing. So for Cushing's, you have increase in cortisol production. So you have increased cortisol. Okay. Cortisol promotes gluconeogenesis. So if naay mo ask nga, what hormone blank is the primary hormone that stimulates or facilitates gluconeogenesis? The answer it is cortisol. Okay? So the effect of cortisol is increase in glucose concentration. Okay? Now, in Cushing's, people with Cushing's, they tend to develop diabetes. But that diabetes is secondary to the primary disease, which is Cushing syndrome. The reason why the patient develop diabetes is because of the increase in cortisol. Increased cortisol, increased gluconeogenesis, the effect, you have increase in glucose concentration. Because gluconeogenesis, that is the formation of glucose from non-carbohydrate source. Okay? Next, pheochromocytoma. So for pheochromocytoma, it's the tumor in the adrenal gland. And that tumor produce excessive amount of catecholamines. Example of catecholamines, you have your epinephrine. Okay? And epinephrine, it's a hyperglycemic hormone. It promotes glycogenolysis. Meaning of glycogenolysis, diba? It's the breakdown of glycogen or the conversion of glycogen to glucose. So the effect is increase in glucose concentration. Okay? So the patient developed diabetes due to increased epinephrine. So it is secondary to pheochromocytoma. Okay? Acromegaly, you have increase in growth hormone, and growth hormone promotes glycogenolysis. Okay? So same with pheochromocytoma, the diabetes is secondary to acromegaly. Okay? For hyperthyroidism, same mechanism. It's secondary to hyperthyroidism. So hyperthyroidism, you have increased thyroid hormones, and thyroid hormones facilitate glycogenolysis and gluconeogenesis. So effect, you have increase in glucose level. Okay, so increase glucose level, then uh, you have diabetes, but that is secondary to glucose, secondary to the endocrine disorder like hyperthyroidism. Okay. Then next, you have drugs. So example, the drug dilantin. Okay, so dilantin. So dilantin is a drug. It's an anticonvulsant drug, and it's usually used to. It's an anticonvulsant, and the effect, uh, it inhibits the secretion of insulin. Okay, so that is for dilantin. Okay. Then next, you have genetic disorder like Down syndrome and Klinefelter syndrome. So for Down syndrome and Klinefelter, people with Down syndrome and Klinefelter, they tend to develop insulin resistance. They're prone to insulin resistance. Okay. Next, you have exocrine disorder like cystic fibrosis. So for cystic fibrosis, the body is producing thick mucus. And mucus serves as lubricant, di ba, on top? But for cystic fibrosis, you have increase or production of thick mucus. Okay, so it can cause accumulation. Okay, cystic fibrosis, there's accumulation of thick mucus and thick digestive juices in your pancreas, and that can cause damage to your pancreas. So you have decreased production of insulin. Okay, so that's for other specific types of DM. Okay. Next, you have notes. Standard specimen for glucose measurement, it's venous plasma. Okay. And if you're going to use serum specimen is appropriate for glucose analysis if serum is separated from the cells within 30 minutes after collection. Okay. So venous blood glucose is 7 mg/dl lower than capillary blood. And CSF glucose is 60% of plasma glucose concentration. So meaning, if the glucose concentration in plasma is 100 mg per dl, the glucose concentration in CSF is 60%, 60 mg per dl. Okay? And remember, the CNS is highly dependent on blood glucose. Okay? It cannot store or concentrate your CNS. Next, you have plasma glucose increase with age. So what is the expected increase in glucose as you age? So first, for fasting, it's 2 mg per dl per decade. Okay, so for example, at 20 years old, your glucose concentration is at 80, then 30, you have 82, then 30, no, 40, you have 84, then 50, you have 86. So this is the normal progression or increase in glucose concentration as you age. But if you have a bad lifestyle, then we'll expect that the increase is also um, So, abrupt. Okay, so for example, for the first uh, for the first decade or uh, every decade or per decade you have increase in 10 mg per dl or 20 if you have bad lifestyle. Okay. For postprandial, it's 4 mg per dl per decade. Glucose challenge, it's 8 to 13 mg per dl per decade. And that's the increase, no? For the decrease, for uncentrifuged blood specimen, the decrease at room temperature, it's 7 mg per dl per hour. And 4 degrees Celsius, it's 2 mg per dl per hour. So serum specimen without bacterial contamination or leukocytosis results remain clinically acceptable even after a delay up to 90 minutes before separation of serum and cells. But we need to process the specimen immediately or as soon as possible in order to avoid false decrease because we'll not know if there's a presence of bacterial contamination or leukocytosis. Okay. Okay. So next is the organs responsible for glucose control. So first is the liver, pancreas, then third you have other endocrine glands. So liver stores glycogen. Glycogen is a stored form of glucose, and liver performs glycogenolysis. So it's the site for glycogenolysis and gluconeogenesis. So if you talk about glycogenolysis, that's the breakdown of glycogen. Gluconeo, that's the formation of glucose from non-carbohydrate source. Then next, pancreas, you have beta, alpha, and delta cells. So beta, production of insulin, alpha, production of glucagon, delta, production of somatostatin. And pancreas is both an endocrine and exocrine gland, meaning for endocrine, you have the production of hormones, exocrine, production of enzymes like amylase. So pancreas produce amylase, lipase, and protease. Amylase is for the breakdown of glucose, lipase is for the breakdown of fats, protease is for the breakdown of proteins. Okay. Now, for the hormones, insulin is the primary hormone, or not primary, the only hormone that facilitates the entry of glucose into the cell. Okay, insulin. And it is released when glucose level is high. Okay, so the stimulus for insulin production is increased glucose concentration. Okay. And regarding insulin, it promotes glycogenesis. And meaning of glycogenesis, it's the formation of glycogen from the extra glucose. You have the conversion of excess glucose to glycogen. Okay, that's glycogenesis. Yeah, so if there's an excess if there's excess glucose in your blood, that excess glucose will be converted to glycogen. Okay. Then next, another is lipogenesis. So insulin promotes lipogenesis or the formation of fat from excess glucose. So that's why you'll gain fat if you eat a lot of carbs because the carbohydrates, glucose will be converted to fat, okay, by insulin. Then it promotes glycolysis or the breakdown of glucose. Okay, so those are the effects of insulin, and it decreases glycogenolysis. Okay, the rate of glycogenolysis, decrease rate of glycogenolysis or the breakdown of glycogen. Okay, so that's for insulin. For glucagon, it's usually released during stress and fasting state. So the stimulus to that stimulus to primary stimulus for the secretion of glucagon is decrease in glucose concentration or during fasting. Okay, so the action of glucagon, it promotes glycogenolysis, okay, or the breakdown of glycogen to glucose. Okay, so the effect of glucagon is increase in glucose, diba? Because it facilitates or promotes the breakdown of glycogen to glucose. So the effect is increase in glucose. Next, you have adrenal gland. Uh, Adrenal gland is an endocrine gland. So for adrenal gland, it produces cortisol and catecholamines. And cortisol promotes gluconeogenesis. So it's the formation of glucose from non-carbohydrate source. Then for catecholamines, example, you have your epinephrine. Epinephrine inhibits insulin secretion. Okay, inhibits insulin secretion. So the effect of catecholamine or epinephrine is increased glucose because there's inhibition, okay, in the secretion of insulin. And epinephrine promotes glycogenolysis or the breakdown of glycogen to glucose. Okay. Then next, you have your pituitary gland. You have the production of growth hormone. And growth hormone decrease the entry of glucose into the cell. Okay, decrease entry of glucose into the cell. And it promotes glycogenolysis. So the effect, you have increase in glucose concentration. ACTH, it promotes the production of cortisol. Okay. Then next, thyroid hormone. So for thyroid hormone, it promotes glycogenolysis, gluconeogenesis, and intestinal absorption of glucose. It facilitates intestinal absorption of glucose. So the effect of thyroid hormone, you have increase in glucose concentration. Glycogenolysis, breakdown of glycogen to glucose, gluconeogenesis, uh, formation of glucose from non-carbohydrate source, and last, uh, increase intestinal absorption uh, of intestinal absorption of glucose. So the effect, you have increase in glucose concentration. Next, you have hypoglycemia. So hypoglycemia, it's the decrease in glucose level, and it has uh, many causes. Okay, so say hypoglycemia, there is an imbalance between glucose utilization and production. So increased utilization and decrease in production. Okay, so those are the two main causes of hypoglycemia. Warning signs of hypoglycemia, it's related to central nervous system because the CNS is highly dependent on blood glucose. It cannot concentrate or store glucose. Okay, the next, Whipple's triad. So to diagnose hypoglycemia, we usually use you're going to use Whipple's triad in the diagnosis of hypoglycemia. So when I say Whipple's triad, you have three parameters. So first is low blood glucose concentration, then typical symptoms. So for low blood glucose concentration, you can use RBS for this one or FBS. So if the result of RBS and FBS is below 60, then that strongly suggests hypoglycemia. Then with typical symptoms of um, hypoglycemia like dizziness, blurred vision, confusion, palpitations. So those are the typical symptoms of hypoglycemia. And symptoms elevated by glucose administration. So meaning after glucose administration, the symptoms disappear. Okay? So that's how you diagnose hypoglycemia. Okay? Now, 65 to 70 mg per dl of glucose, glucagon and other glycemic hormones or hyperglycemic hormones are released. Less than 60, it strongly suggests hypoglycemia. And 50 to 55, you have observable symptoms of hypoglycemia. So for hypoglycemia, you can use RBS to check for hypoglycemia. Uh, no need not to fast for RBS, but it's random blood sugar. Okay. The next causes, first is drug administration like insulin, because insulin promotes cellular entry of glucose, okay, or entry of glucose into the cell, okay. So insulin overdose can cause hypoglycemia. The next, alcohol. Alcohol decreases the rate of gluconeogenesis, okay. The next, critical illness, you have hepatic failure. So for hepatic failure, uh, you have decreased production of glucose. For kidney failure, you have decreased gluconeogenesis. Okay. And another cause of hypoglycemia, you have malnutrition. Then hormonal deficiency or deficiency in hyperglycemic hormones. Okay. Deficiency in hyperglycemic hormones. Then next, endogenous hyperinsulinism, or there is insulinoma. Okay, insulinoma, meaning there is a tumor that secretes excessive amount of insulin. Okay, and that can cause hypoglycemia. Okay, non-beta cell tumors like leukemia, so there is excessive utilization of glucose due to increased number of WBCs. Then galactosemia. So for galactosemia, the body cannot convert galactose to glucose. Galactose is present in dairy products or milk. Okay, so the body cannot convert galactose to glucose, so there will be a decrease in glucose concentration. Then next is alimentary hypoglycemia. It's due to surgery, or it will happen usually post gastric surgery. Okay, alimentary hypoglycemia. Then next you have idiopathic postprandial hypoglycemia. So idiopathic meaning no known cause. For alimentary hypoglycemia, there is hypoglycemia because of alteration in the gastrointestinal tract after surgery. Okay, so these are the causes, possible causes of hypoglycemia. Okay, so next you have inborn errors of carbohydrate metabolism. So first, you have galactosemia. So cause failure to thrive or failure to gain weight and grow. So children with or infants with galactosemia, um, they cannot, uh, they're unable to gain weight or grow due to the inability of their body to convert galactose to glucose. Okay, so uh, for galactosemia, the common cause of galactosemia is the absence or deficiency in the enzyme galactose 1 phosphate uridyl transferase. So this enzyme is important in the conversion of galactose to glucose. So if this enzyme is missing or deficient, you have decreased glucose formation from galactose. Okay, so galactose is present in milk. Okay, so galactose is part of lactose. Okay, so another cause, you have galactokinase deficiency. So same with galactose 1 phosphate uridyl transferase, this enzyme is needed in the conversion of galactose to glucose. The next is uridine diphosphate galactose 4 epimerase. So, but the most common deficiency is galactose 1 phosphate uridyl transferase. So for this one, for galactosemia, you have elevated blood and urine galactose due to the inability of the body to convert galactose to glucose. Now, the treatment for this one is to, or how to manage galactosemia. So you need to eliminate galactose from the diet. Okay. So for infants with galactosemia, they need to drink soy-based infant formula instead of dairy. Okay. So, or the usual milk na dili sila pwede ana. So ang alternative is to use soy-based infant formula. Okay, to avoid galactosemia or to avoid the complications of galactosemia. Okay. Then next, you have essential fructosuria and hereditary fructose intolerance. Okay, so for this one, the problem is in the breakdown of fructose. Okay, so uh, treatment or management is to eliminate fructose from diet. Okay, same with galactosemia, diba? For galactosemia, you need to eliminate galactose or lactose. For this one, you need to eliminate fructose. Okay. Then next, you have GSD. So for GSD, meaning of GSD is glycogen storage disease. And for deficiencies, for GSD, there's deficiencies of enzymes that control the synthesis or breakdown of glycogen. Okay, so the problem is the breakdown or synthesis of glycogen. So there's the presence of abnormal quantity or quality of glycogen. Okay, so in this disease, glycogen, there's a buildup of glycogen in the liver, and that can cause hepatomegaly. Okay, that can cause liver damage. Okay, now for GSD, there are different types of GSD. I think there are 11 types of GSD, but the most common, you have type 1 GSD. And for type 1 GSD, there's deficiency in glucose 6 phosphatase. Okay, there is glucose 6 phosphatase deficiency. Okay, it's also known as your von Gierk disease. Okay, Gierk, this is K, von Gierk disease or type 1 GSD. So for GSD, there's accumulation or buildup of glycogen because there is an enzyme that is deficient, and that enzyme is needed in the breakdown of glycogen. So there is buildup of glycogen in your liver. Okay, so it can cause hepatomegaly or um, can cause liver damage. Okay, that is for GSD. Next, CSF glucose. So CSF glucose, it's 60% of plasma glucose concentration. Changes in blood sugar are reflected in the CSF approximately 1 hour later due to lag in CSF equilibrium time. Blood sugar specimens should be collected at least 1 hour before lumbar puncture. Okay, it's because uh, na may delay or lag in the equilibrium of CSF glucose and blood glucose level. Okay, so lumbar puncture, this is the method to collect CSF. Okay, so the site of collection, it's in between third and fourth or in between fourth and fifth. That's the usual location for lumbar puncture. In between 3 and 4, L3 and L4, in between L4 and L5. So increased CSF glucose, example, disease with increased CSF glucose, you have diabetes mellitus. Decreased CSF glucose, you have meningitis or inflammation of the meninges, either bacterial or fungal. So there's a decrease in CSF glucose due to the consumption of glucose by the microorganisms. Then another cause of decreased CSF glucose, you have hypoglycemia. Okay, remember, CNS cannot store or concentrate glucose. So it's highly dependent on blood glucose concentration. So if there's a decrease in blood glucose level, there's also a decrease in CSF glucose concentration. So reference range is 60 to 80 mg per dl. So this is the normal CSF glucose concentration. Then next, you have C-peptide concentration. So for C-peptide, it's formed during the conversion of proinsulin to insulin. So for example, you have your beta cells. Your beta cells produce proinsulin. And after that, this proinsulin will be converted to insulin. So this one is the active hormone. This one is the prohormone. So you need to convert the prohormone to the hormone, which is active. Now, in the conversion of proinsulin to insulin, another product of this conversion is the C-peptide. Okay? So in terms of concentration, C-peptide is uh, abundant or higher concentration compared to insulin. Okay? That's why it's the more common test than insulin, the C-peptide level. Okay, it's because of its concentration. It has higher concentration. Now, in the conversion of proinsulin to insulin, the other product is, or the product, or it's the substance form, it is C-peptide. Okay, so for example, if there's beta cell destruction, the proinsulin level is low. So you have low conversion of proinsulin to insulin. And also the C-peptide level is also low because it's dependent on the conversion of proinsulin to insulin. So it's a reliable indicator of pancreatic and insulin secretion. So if there's decreased insulin, meaning there's also decreased C-peptide level. And if there's a problem with your beta cells, the production of C-peptide is also affected. Okay? It's also used to monitor individual response to pancreatic surgery, and it evaluates hypoglycemia and beta cell function. The specimen, it's fasting serum, okay, because after a meal, it's also expected that the level of C-peptide is increased. So C-peptide is affected by the recent meal. Okay, so the specimen should be fasting serum. So increase C-peptide if there's insulinoma. So in insulinoma, diba, there's a tumor that produce excessive amount of insulin. So increase insulin, increase C-peptide. Type 2 DM, in type 2 DM, diba, there is insulin resistance. The production of insulin is normal. So that's why there is increase or detectable level of C-peptide in type 2 DM. For type 1, the C-peptide level is decreased because there is beta cell destruction. So decrease beta cells or destruction of beta cells, you have decreased proinsulin. Decrease proinsulin, decrease insulin and C-peptide level. Okay, so that's for C-peptide. Reference range 0.9 to 4.3 nanogram per ml. Okay, so that's for C-peptide. Then last, you have your ketone. So for ketone, it's a product of fat metabolism. And types, you have acetone 2%, acetoacetic acid 20%, beta hydroxybutyric acid 78%. So produced in cases of carb deprivation, then DM, starvation, and GSD, glycogen storage disease. So there's also presence of ketones in GSD because the body cannot convert glycogen to glucose efficiently. Okay, so to look for another source of energy. So the specimen, it's either fresh urine or serum. Okay, so ketosis can be reversed through restoration of proper carbohydrate metabolism. And for the test, for ketones, you have Gerhard's test. So Gerhard's test is for uh, the measurement of acetoacetic acid. Okay. Then next is sodium nitroprusside. So for sodium nitroprusside, um, um, for sodium nitroprusside, this is the principle, diba, in your chemical urinalysis for ketones. Okay. So it's used to measure acetoacetic acid. But if you're going to add glycerin to the reagent, then you can also measure acetone. Okay. Then ketosite assay, this is for the measurement of beta hydroxybutyric acid. Okay. So this is an enzymatic assay. So you'll use beta hydroxybutyric oxidase. Okay. That's for ketosite assay. So ketones usually increase in patients with DM, particularly type 1 DM, but there are cases of type 2 DM that will develop ketoacidosis. Another, you have carb deprivation, starvation, okay? You have increased ketone production and also GSD, okay? So that's it for our discussion regarding carbohydrates. Thank you.